We want to say good morning to everybody out there in radio, TV, and internet land. And I'm going to tell you this right now. If there's somebody in the house, or if somebody in your car, or what have you, that can have access to this interview, then I want you to get their attention and tell them to come on down because we're going to discuss something that's very, very important with an individual who's very versed in what we are going to discuss. And, for years now, we've been doing health sections. And this morning, we've got a physician that's going to talk, a medical doctor that's going to talk to us about the lungs and thoracic and, just all kinds of things, the throat, all kinds of things that affect us. And oftentimes, we hate to hear the words that it's too late, So he is also going to discuss some preemptive, if you please, measures, some health measures, some life measures, some preventative measures that we can take in an effort to prevent having to come to him. Strangely enough, he would rather we not have these conditions, but thank God that we've got somebody who can address them once we get them. This is a call to action. I'm your host, Alex Habersham, and again, we are continuing with our Atrium Health series by interviewing this morning. We're so happy to have with us Dr. Anthony Holden, who is, I'm going to let him, all I know is that the correct pronunciation of the THO word is thoracic. So I'm going to take it from there, let him take it from there. Good morning, Doc.
Good morning, Mr. Haversham. Thank you for having me today.
Yes, sir. Let's talk. Just tell us a little bit about yourself.
I was born and raised in a small town in Alabama, and my mom never went to college. My dad did, and he worked at a floor tile plant. My brother and I were really the first to go off to college. My brother became a lung doctor, a
Wow.
pulmonologist, and I became a thoracic surgeon. And I have to chuckle. That's, you know, two guys that same upbringing that ended up in the same region of the body. So I always think back, why did I do that? And my dad smoked, and so I think psychologically that made me want to help people in that field. My practice is cardiothoracic surgery. I do open heart surgery, I do valve surgery, and I do lung surgery. And I have a special place in my heart for lung cancer surgery, and it's probably because of my upbringing. So, so what I did is, I joined the group here about a year and a half ago, and one of the charges that we had was to help elevate Central Georgia's cardiothoracic program, where we do heart surgery, valve surgery, and lung cancer surgery. Now, what we did is we took the um, we took the region and looked at it and thought, well, the guidelines, the national guidelines would say we should look more at people proactively, much like mammograms for breast cancer. We have a screening program that we recommend people follow. And what we say for people who have smoked more than 20 years, um, their current smokers are stopped in the last 15 years, and they're between the age of 50 and 80. We should offer these people a CAT scan for screening. Like a mammogram for breast cancer, we do a low dose radiation CAT scan to look at your lungs. And invariably, we find tremendous numbers of pulmonary nodules, little spots on the lung. Now, the question is, what do you do with these spots? So they all have certain characteristics that we look at on X-ray, and sometimes we recommend following them and repeat the CAT scan in 3 to 6 months, or biopsying the lesions. Now, when we recommend biopsy, there's two different ways to do that. One way is where we'd have the radiologist put you in the CAT scanner and they stick your lung from the outside in to get a sample. You can imagine that's pretty difficult because you're breathing, and that means that little spot will go up and down, and we're asking the radiologist to find it and stick it with a needle.
Right.
Good at it. They're pretty good at it, but it's still a challenge, and sometimes it comes back non-diagnostic, and they put you through the risk of sticking you with a needle. Now, and they can only really stick you once or twice before the risk of collapsing the lung is significant. So we've come up with a different program here, and we call that a robotic driven navigational bronchoscopy. The brand name is the Ion. It's a wonderful system, and what we do is we have a CAT scan that shows us where the spot is. We put that into the computer on our robot, and it maps out a course that we follow with a very tiny bronchoscope. We'll pass the bronchoscope out into the lung, and then we look at the nodule with a special ultrasound machine. And then we have this very, very fancy CAT scan or fluoroscopy that gives us a CAT scan image of the spot. So we know that our sample is inside the lesion or not. But then we biopsy it. So we call that an ion navigational bronchoscopy, and we're successful, about 90% of the time.
Wow.
Now, these are very small nodules, and we've honed our program down to we're doing lesions that are less than a centimeter. So a centimeter is, 25 centimeters is an inch. So we're looking at a half inch or smaller lesions, which is really amazing. The importance of a small tumor versus a large tumor is small tumors tend not to metastasize to the lymph nodes or to other parts in your body. So if we can find a very small lesion and we can resect that, then that's a very, and your lymph nodes are negative, that's a very good chance for cure without radiation, without chemotherapy. So that's our goal. So what we've been doing is when we find somebody with a pulmonary nodule that's able to be biopsied and it has the characteristics that make us worry about it, we'll do that. We'll biopsy these folks and then plan to do a resection and sample the lymph nodes. We try to do that within a month of recognition of the nodule if it fits certain criteria. And so now you have somebody that comes in with a spot, and we go through the process and we kind of streamline it so it's really accelerated. They're seen and treated all within a month, which is remarkable. That's something that this region hasn't had, and we're reaching out to South Georgia, all the way up to Atlanta, so that our program can be the best in the region.
Oh, that's outstanding. That's outstanding. It's phenomenal and it's almost amazing. It's even better than AI, as it relates to being able to discover, detect, and what have you. So, talk a little bit about the conditions because I'm sure, there are several of our listeners and viewers who are wondering, so, hmm, should I go through this process or should I look at my history or not only me, but maybe somebody I know, my friend, my neighbor, my parents. So
Absolutely.
really, who should, because we don't just want this, we don't want this information to be conceived and perceived as pie in the sky.
No,
It's
this is very, very simple process. You look at somebody who has smoked for greater than 20 years and their age, the screening, this is for screening alone, it's between the age of 50 and 80 who have been smoking for greater than 20 years, or they've stopped 15 years ago. Okay. Now, if you fit that criteria, you should undergo a lung cancer screening CAT scan. Now, it's easy to get. You can come to the Atrium Hospital. Your provider can order it. You can go to the cancer center, and not every pulmonary nodule is cancer, but that's how we have it set up. We have a pulmonary nodule screening program there, and you can get the CAT scan, plain and simple. So if you smoke, you've done it for more than 20 years, get a CAT scan. That's the easiest and best way to find these nodules.
Let me ask you something. There are certain circumstances and conditions where people could have a need for these tests, even if they didn't smoke. I mean, do people who have not, did not, and do not smoke have, is it possible for them I mean, are there certain conditions you say, well, maybe you didn't smoke, but it would not be harmful. It might be good for you to go ahead and do it. And while you're talking, talk a little bit about you talked about the diagnosis and the discovery. Talk a little bit about the treatment and the likelihood of success with the treatment.
So, other conditions, if you lived with somebody that smoked a lot or worked somewhere where there's a lot of smoke, secondhand smoke is very important. So you may not be actually smoking, but you're actually breathing all the smoke. So those people should also think about getting a low dose CT for pulmonary nodule screening. That's one thing. But anybody that has lung problems should probably see a lung specialist, and those providers will direct you which way you need to go with that. So yes, other conditions can cause pulmonary nodules, and the pathway is kind of the same. Once they identify the pulmonary nodule, we look at it with certain criteria and decide, should we follow that with repeat CAT scan, or should it go to biopsy?
Okay, now once that happens, thank you so much for that information. Once that happens, and let's say it's discovered, I mean, a lot of people worry about cancer, not only lung cancer, thoracic, other forms of cancer. Just talk a little bit about, you can talk specifically about the treatment, that you render after having discovered based on these tests that you do.
So there's a couple of different ways to treat lung cancer. If it's advanced, we have the medical oncologist look at you for chemotherapy, pardon me, chemotherapy and immunotherapy, which are the pill or chemotherapy through the vein. That's very important because it goes all throughout your body. And if you have lymph nodes that are involved, they also get treated with the chemotherapy. Now, radiation therapy is kind of a non-surgical way of treating a spot. We typically, if you are a candidate for an operation, you should go through the operation as opposed to having radiation therapy or chemotherapy as your sole treatment. So if you can tolerate an operation is very good in getting the cancer out. Now, the operation it's changed over the years. When I first started doing this, we would make incisions between your ribs, and we would spread the ribs apart, and I'd stick my hands in and take out that part of the lung. Nowadays, we do it with a robot. It's absolutely amazing. I make 4 holes, and I try to put them all in the same rib space, and I put my instruments in, and I control it with a console that's sitting next to the patient. And I'm able to take out a portion of the lung with the robot, minimal incisions. And the nice thing about that is it doesn't hurt very much. We leave a drainage tube in until we don't need the drainage tube, take it out, and then you can go home. Most people in my hands go home the next day after having part of their lung out. In the old days, when I would make an incision, sometimes they were in the hospital, 7, 8 days.
Wow.
So it's a tremendous advance in their care. Now, one of the other things that we do when we're doing our operation is we we, we perform rib nerve blocks, or we freeze the rib nerve so that there's hardly any discomfort associated with these operations, which is truly, truly amazing. Um, to think you can come into the hospital, you know, go through a very advanced type of bronchoscopy, have a sample, and then within a month have part of your lung out, your lymph nodes all sampled to look to see if there's cancer in the lymph nodes, and then go home in a day or two without needing a lot of pain medicines. It's absolutely mind-boggling. It's amazing. It's the state-of-the-art care that we strive to get in this region, and I'm very proud of it. Now, if your lymph nodes are positive, then that changes things a little bit. We have the medical oncologist evaluate you and decide if you would be served with chemotherapy in addition to the surgery, or immunotherapy, which is a type of oral chemotherapy sometimes, and or radiation therapy for the lymph node bed. So we try to do a multidisciplinary approach. It's just not my way, your way, or his way. It's all of
Right.
our way. And we work a remarkable team effort for this. I'm very proud of it. Now, the other thing about it is people who get lung cancer, the majority of them are smokers. And those people also have probably bad lungs because of their smoking. And now we're removing part of their bad lungs, which leaves them less bad lungs. So we involve our pulmonary doctors in all of these cases to help with the pulmonary medicine standpoint of this, to help their quality of life. Some people need inhalers, some people need oxygen, but all that stuff is part of a multidisciplinary team to make care better for everybody.
Well, we're certainly interested in people living long lives, even if they have certain conditions. And I'm sure that there are a lot of people, out there who have passed and who probably could still be living had they had the
Absolutely.
option, had they had the option or the privilege of learning and ascertaining this kind of information. So we're so appreciative of that. Now, I think we it behooves us, you and me, to repeat those conditions as it relates to smoking, because a lot of times people who have quit smoking feel like that they are out of the woods. But when we come back, we're gonna take a break for a minute. When we come back, we're gonna repeat those conditions and do another encouragement sector for people to get examined. So we want everybody to live as long as possible. This is a call to action. I'm your host, Alex Habersham, interviewing Dr. Anthony Holden, a thoracic surgeon, and amongst other things. We'll be right back. We're back. This is a call to action. I'm your host, Alex Habersham. Thank you for joining us. Doc, would you kind of discuss those conditions again?
Be happy to. So, folks who have smoked more than 20 years in their life should probably be considered for lung cancer screening. And that's a pretty simple thing. It's just a low dose radiation CAT scan. You have it's easy to get. If you have a doctor, they can order it. If you don't have a doctor, you can reach out to Atrium, and we'll figure out a way to get it ordered for you. Now,
Uh,
people who smoked more than 20 years in their life, even if you've quit within 15 years, you should be considered. And the age range we look at is between 50 and 80 years old. These people should be checked, okay, because all of that goes hand in hand with lung cancer. Um, the best medicine for lung cancer is don't get it. And the best way to not get it is to don't expose yourself to tobacco. So that means don't smoke, don't vape. Those are really important. But some people who live with people that smoke are still exposed to tobacco, and they should be considered for screening also. Now, if you come up with a pulmonary nodule, then don't ignore it, because if it's a cancer and it's an early stage tumor, a very small tumor without lymph node involvement, removing it sometimes is curative, meaning it cures you and you don't have to worry about lung cancer. Now, one of the bad things about lung cancer is when you smoke, the carcinogens in the tobacco smoke goes all through your lungs. So you may get cancer in one spot, but 10 years later, you may get it in another spot. So it's also very, very important to be vigilant about that in the future. People who get lung cancer and goes through therapy, we follow those people with CAT scans and PET scans for the remainder of their life on a certain time frame, and that helps to look for recurrence and things like that. So in the old days, it was a death sentence because we didn't know people had lung cancer until it was very advanced. So it would block off part of their lung and they couldn't breathe, or their lymph nodes were involved. The goal today is to find it early before it spread so that we can take care of it with a good chance for long-term survival.
Really, our objective is to get people to live longer and to be healthy. And, I applaud the effort. It's so important to our community. And I applaud you too. And your interest in, making a difference in the lives of people. Now, I noticed you mentioned vaping and other kinds of smoke. What about if you have worked in an environment, where, there were fumes and smoke?
You can get lung cancer for a lot of reasons. You can get pulmonary nodules for a lot of reasons. Not every pulmonary nodule is cancer. Um, but yes, if you've worked in a factory that has dust particles, or if you worked in a factory that has, you know, certain types of vapors and things like that, you can get lung disease from those problems that aren't necessarily cancer. That's why we try to do this with a multidiscipline approach. We have the lung doctors get involved and see what they think about your breathing. You might be short of breath because you have something wrong with your heart. You may be short of breath because you have something wrong with your lungs. Doesn't always mean it's lung cancer. But yeah, occupational exposure is a really big deal because you can have infection, you can have damage to your lungs, all from the occupational exposure, or you can have lung cancer.
Yeah, yeah. What about asthma? Is there any connection between asthma and lung cancer? And do you have any experience in treating asthma?
So I don't treat asthma. I'm a surgeon, and the asthma is usually treated by the pulmonologist. So my conversation will be limited in that. But there's not really necessarily a connection between asthma and lung cancer, except the exposure of the chemicals, the tobacco, the vaping, and things like that.
Yeah, yeah. You
You can
mentioned,
have both problems.
yeah, you mentioned, also mentioned vaping. A lot of people, feel that, their answer to continuing to get the nicotine and what have you is through vaping. So is that a better alternative than smoking?
So I would say no, because you're trading one um, injury to your lung for another injury to your lung. So smoking cessation is a topic in itself. Going from tobacco to vaping is not a good solution. If you want the nicotine fix while you are stopping smoking, there's a number of ways to do that. The gum, nicotine patches, all of those things can help you get off of tobacco. But the key to it is to get off of tobacco and nicotine. Nicotine is not benign. It's bad for your heart, bad for your arteries. So you may survive lung cancer, but you may have a heart attack. All of that stuff is combined. So I tell people you need to stop smoking, but you also need to stop your exposure to nicotine. And some people need a crutch, like a patch, to get off of it. Some people use the pill, a Chantix, for that. There's 100 different ways to quit. And the state has a million different things to help you quit. Your primary care doctor does too. The real thing is stop smoking, stop nicotine exposure.
Well, then I think you are saying, although one may have a history of smoking, that it's never too late to quit.
It's never too late to quit.
Yeah.
One thing that people realize is that the day you quit smoking, that is the day you stop having the exposure to the carcinogens. And so, like I said, if you quit 15 years ago, we don't screen people. That means you probably won't get it if you quit that long ago. So quitting is important.
Yeah. So, but if it's been less than 15 years since we talking about getting the exam now. So I think
Correct.
it needs
The
to be
screening
repeated.
test.
Yeah.
The screening test. If you have symptoms, you should be tested.
So even if you quit less than 15 years ago, or if you continue to smoke today, you need to get that screening test. Just take another minute to talk about that test and how it works and what it detects, if you would, because it's important and it's kind of new technology, and it's good to hear that they've got that kind of advancement in the detection and diagnosis.
The screening test is very simple. It takes less than a minute. You lay down on a table and you go through a CAT scanner. That's it. And that gives us the information if you have a pulmonary nodule or not. If you have a pulmonary nodule, you'll be seen by one of our providers in our pulmonary nodule service, and we'll make the determination if you need a biopsy or not. And then if you need a biopsy, you typically will come to the navigational bronchoscopy where we do samples. And then if indicated, we would offer you an operation for resection.
And I really appreciate Atrium for trying to take a holistic approach.
Well, I'd like to thank you for allowing me to talk to you and your audience regarding lung cancer and the options that are available to the community via Atrium Health. You know, Atrium has been a great supporter of our program, and our door is open. So please, if you have anybody, a loved one, a friend, family members that are smokers, they need to be screened if they fit the criteria. And if we find an asymptomatic pulmonary nodule, it could mean saving their lives.
Thank you so much, Dr. Holden. This is a call to action. I'm your host, Alex Halversham. Have a great day.
www.makingblackpages.com